Oh
Uh,
my gosh, it's so great to see where everyone's joining from.
yeah,
From Houston and Oakland, Chicago, Santa Barbara, another from Chicago, fantastic, Boston. Oh, this is really wonderful.
yeah, please keep introducing yourself in chat. And just some quick housekeeping so we can go ahead and get started promptly. If you would like subtitles for this call, you should be able to click the closed captioning button and turn subtitles on. And you might have to also click subtitles to get those going on your screen. The discussion is going to run for about 1 hour and will be followed by a 30-minute live Q&A with all of you out there in the internet land. And for the question and answer portion, if you do have questions, please feel free to, there's a Q&A button down kind of at the bottom of your screen, and that is the best place to be dropping questions. Spotlight Trust co-founder Lisa Lambert will be hosting the chat side and also be kind of moderating the Q&A and supporting any technical questions that come up. So feel free to put it at Lisa in the chat and she will do what she can to help you out. Last thing, just we wanted to let everyone know that this is being recorded, so any comments or questions may be part of that recording. It'll be sent to all of the registrants and will be edited and released as part of the Intrust podcast in a few weeks. And during the live Q&A, we may ask people if time permits to come off mute, and we'll kind of give you the ability to let your voice be heard. And obviously that would be recorded if you decide to come off mute. And lastly, we would like to just make sure after the conversation, we'll talk about this again a little bit more. We'll want to keep the discussion going. So please feel free to share your thoughts and questions on Twitter and LinkedIn with the hashtag #EndMedMistrust. So we are so stoked to have people from all over the world in this, and figure I might as well introduce myself as the guy who's talking. My name is Rick Kitagawa, pronouns he, him, his. I'm one of the co-founders of Spotlight Trust, a consultancy and trading organization that seeks to help organizations make the future of work better through the practical application of trust. I'm also the co-host of the Intrust podcast, and I am so excited to be one of the moderators for this discussion again today. And I will pass the mic to my fellow moderator, Shannon Weber.
Thank you, Rick. I'm so excited to be here and looking forward to learning from this conversation. My pronouns are she and her, and I'm a settler on the unceded territories of the Ohlone people, also known as San Francisco. And I'm the founder and director of Please Prep Me, a go-to online resource for HIV prevention. And I have a devotion to innovative community-based solutions and creating connection, which involves practices of cultivating empathy and trust. And that's what brings me here today. So Lisa is going to drop the official bios for our panelists into the chat, but we want to invite each of the panelists to introduce themselves in 2 or 3 sentences, including why this conversation that we're having matters today to you. And we'd like to start with you, Sean.
That's great. Well, good afternoon, everybody. My name is Sean Dimmons. I am a capacity building specialist with the Center for AIDS Prevention Studies at UCSF. And what brings me to this conversation is I teach a lot on practicing cultural humility and working with trans communities. And also just brings me here as a Black trans person who has, a response to these types of questions and who has had family conversations about what this means historically, and how I've learned about, why some of my family members have, avoided care at certain times.
Thanks for being here, Sean. Dr. Blackstock, we'll go to you.
Good afternoon. Thanks so much for having me. It's such a pleasure to be here. So I am a HIV and primary care physician, also a researcher and public health advocate. I think similar to Sean, these issues around medical mistrust come up frequently. So in my encounters, with my patients, when it just comes to even something like the flu vaccine, and then even more now with COVID-19 in the news, and with a potential vaccine. So very much sort of grappling with these similar issues when it comes to the care I'm providing to my patients, as well as conversations with family.
Yeah, it's so alive. Thank you for being here. And Dr. Gomez, we'll go to you.
Yes, hello, everyone. Thank you for joining us. A pleasure to be here with my colleagues. I am a trained clinical psychologist, but I have spent most of my career as an HIV behavioral scientist and health policy influencer. Spent 14 years at UCSF at CAPS, where Sean is at, and then had the opportunity to move on and work on a broader front and created the Health Equity Institute at San Francisco State. I am now retired from the academy, but I continue my work a lot with nonprofit organizations, federal advisory committees, and consultancies in the area of health equity in particular. I'm really excited to be a part of this discussion. I feel strongly that medical mistrust really is one of the challenges in achieving health equity. And this is a context where it's showing up in many different ways. And I just look forward to diving in more deeply on the topic.
Thank you so much for being here. So as you know, this is a two-part series, and I want to give a background for the series as well as how we're thinking about framing up specifically the conversation we're having today about understanding the history. So understanding where we've come from so we can really be thoughtful about where we're going. In 2020, there's been these numerous disruptions that have really put us into this series of crises that we're struggling with. And with that, it puts us in this liminal space. It's a space that's in between where we once were and where we are going. So there's been an astronomical number of COVID cases and deaths. There's been natural disasters, and the economic impacts of these disasters and COVID have also impacted mental health and burnout. And importantly, there's been a refocus on what it means to value Black lives and what it looks like to stand up for racial injustice. I want to read from a chapter that Dr. Arundhati Roy, the author of The God of Small Things, has shared from her upcoming book. And this chapter is called The Pandemic is a Portal. Whatever it is, coronavirus has made the mighty kneel and brought the world to a halt like nothing else could. Our minds are still racing back and forth, longing for a return to normality, trying to stitch our future to our past and refusing to acknowledge the rupture. But the rupture exists, and in the midst of this terrible despair, it offers us a chance to rethink the doomsday machine we have built for ourselves. Nothing could be worse than returning to normality. Historically, pandemics have forced humans to break with the past and imagine their world anew. This one is no different. It is a portal, a gateway between one world and the next. We can choose to walk through it, dragging the carcasses of our prejudice and hatred, our data banks and dead ideas, our dead rivers and smoky skies behind us, or we can walk through it lightly, with a little baggage, ready to imagine another world and ready to fight for it.
And while the disruption of the pandemic has a lot to offer us in terms of imagining a new future, at the same time, COVID has had a disproportionate impact on communities of color. Even with the vaccine on the horizon, according to a study conducted by the NAACP, Unidos US, and the COVID collaboration, less than 15% of Black communities polled believe in the safety of a vaccine, and less than 35% of the Latinx, Latina community believes in its safety. For communities that have been so greatly impacted by COVID, building trust is essential to save lives. And in order to build trust, we first need to understand why medical mistrust exists in the first place. And that's why we have this stellar lineup of panelists here today. So let's get to it.
All right, great. Thanks, Rick. So to begin, I want to do a round robin, giving you each a chance to respond to these two questions, which is one, how do you define medical mistrust? And then two, how does medical mistrust show up in your day-to-day? Who wants to be the first?
Sure, I'll get started. So I think of medical mistrust as not just a lack of trust in the healthcare system, so in healthcare providers, treatment hospitals, but also a belief that the healthcare system is acting with ill intent toward a certain individual or certain group, typically marginalized group. And I think of it as often extending beyond the healthcare system to pharmaceutical companies and government. And I see it, at least as a healthcare provider, showing up in a number of different ways. I'm not sure if you want us to talk about that now, but I could share, for instance, when I see a patient who doesn't ask questions or make eye contact, seems uncomfortable, may not verbally agree with my recommendations, that sort of lack of engagement in the healthcare interaction might be a potential sign. When patients may be non-adherent or to their medication or to visits, that could be a potential indication. And then, sometimes patients will say outright, I don't trust this medication. I don't like it for these reasons. This is, this might be poison. I don't know. So sometimes we get actually direct statements that we can then address. But I think of it as sort of coming out of sort of a system, the culture in which we live, all the various isms, phobias, and it being a reaction to those experiences that people have.
Yeah, I appreciate that you ask or have us thinking about it being defined very broadly. And I think with online communications that where they are, the bleed is all over, right? Into these various other, outside of the hospital. And so it's so important to think how that impacts the work that we're trying to do or the messaging that we're trying to get out. So Sean or Dr. Gomez, do you want to go next? How do you define medical mistrust and how does it show up in your day to day?
Sure, I'll jump in. I mean, just to build on what's already been said, I think it's important to first of all acknowledge that it's also sort of a broad statement of a very complex interaction. So we call a lot of things medical mistrust, and it happens at the individual level, at the familial, at the societal level, and it has layers. So I think of it really as a transactional event, and in that sense, it's very relational. So medical mistrust is very relational in my mind because it is about building trust between one entity and another, and how do we do that? And I think layered on that, as we've spoken about so far already, are the other intersectionality phenomena. So whether it be then added on top of that mistrust, structural racism within a healthcare organization, whether it's seeing that people are making money off of meds or devices, or how the health insurance companies are deciding what you can get for your medical treatment. All of these things feed into medical mistrust. And how I see it every day really varies on what hat I'm wearing. So, in mental health, when I was the clinician, it was so important that I developed, that I became a trustworthy person first, before I expected my patients to trust me in that very intimate interaction as a psychologist, where people really share their biggest secrets, if you will. On the other hand, as a researcher, it was really about how do I help a community feel safe in participating in the research that I am conducting. And there it really showed up in being transparent of what we were doing, why we were doing it, and how it would benefit their community. That it wasn't just a take, if you will, which many communities have experienced. And finally, as a patient myself, I mean, I have to say that I've experienced in my day-to-day, that unfortunate bias that we see in healthcare systems, whether it be a specific provider. I'll give you a couple of examples. One, I took my 98-year-old mother to see an ophthalmologist, and I wasn't very well dressed. I was in t-shirts and jeans, and I'm Mexican American, but this provider sort of assumed that I was not educated, would not understand anything that they were thinking about proposing or not proposing to do for my mother. I asked a couple of questions, but the response was clear that they assumed I would not know enough. I was not health literate enough. And I didn't say anything at the moment because I felt I didn't want to embarrass or shame the provider, but I later called her and said, look, I'm a Harvard educated person. I'm in the healthcare field, and I really resented that you made that assumption. And then in general, I feel like I find myself in healthcare systems having to say what my background is to establish legitimacy in my interaction with providers. And that's a really sad sad thing that many of us have to do. So those are ways in which it shows up day to day.
I don't have that much to add. I think you all kind of covered how it's defined, but certainly how it shows up in my life day to day and interacting with healthcare facilities is just, it comes from my experience of structural racism in general. It comes from who runs these facilities. And even though I'm not Harvard educated, but I have a little bit of education. I have, a graduate degree. And so that I am able to understand what a provider is saying to me, but it's about trusting, or do they have my best interest in mind? Am I getting the best treatment, or are you just trying to keep me in this loop to make money? And something that's helped me in that, I think, and I have too many experiences to name, as being a Black person, a queer person, a gender non-conforming person, and now a transgender person going into access healthcare. But I'm a very strong self-advocate, and I have a lot of resources, but that's not the case for all folks that come from the communities I represent. And so I am generally skeptical, even though I've had research experience, even though I work with researchers, even though I work with doctors and medical doctors and PhDs. I still have an experience of structural racism. I still have the stories that come through my family. I still have family members who have died for not wanting to go in. I want a doctor cutting on them or taking a medication. It's just, that type of thing. That's how it shows up in my day-to-day life. And I think someone mentioned, I think Dr. Oni mentioned a flu vaccine. I don't do flu vaccines, and I was very upset. I was forced to take a flu vaccine this year because it's a USSF policy. And I had to really think about that. Like, what am I going to do? This is something I don't want. I don't even remember the last time I took a flu vaccine, and I don't get the flu. I've been washing my hands and, not touching doorknobs before coronavirus showed up, because that's just kind of what I do, because I know that's how germs are, transferred. But yeah, I felt like I really felt deeply about being forced, having this shot forced on me that I don't trust. I don't trust them. I don't want vaccinations. But
Mhm.
that's me.
Thank
Yeah.
you so much for sharing that.
Yeah, thank you, everyone, especially for sharing those very personal stories. And I think that's a great segue in a way to the next question. So, Dr. Blackstock, a focus on your recent work has been on illuminating the harms of anti-Blackness in medicine. And we'd love to hear a little bit more about the historic elements of modern day medical mistrust through that lens.
Sure. Well, it could be a whole course or a whole presentation, but I'll give like the very abbreviated version. And I think back to, so Harriet Washington's Medical Apartheid, which I hope everyone in the audience has read or is reading, just to say it is very disturbing, some of the details. So you may not be able to read it sort of like consecutively. You may have to like stop a little bit. But anyway, she referred to, starting with the transatlantic slave trade, she referred to that as a medically managed enterprise, because doctors were really charged with inspecting enslaved people before they were forcibly taken to slave ships. Doctors were hired to ensure that the quote unquote cargo remained alive and healthy enough during transport. There was even a law mandating that physicians be on many ships transporting kidnapped and enslaved African people. And then, during this time, during the 18th century, we saw the concept of race kind of birthed. And this idea of racial categories was in many ways reinforced by folks in the medical field, by physicians who really fabricated, differences in medical and mental and physical defects of Black people. So for instance, thinking about phrenology and suggesting that Black people's brains were smaller. An interesting tidbit is that there were thought to be, by the white medical establishment, differences in manifestations of certain diseases, including syphilis. So there was a thought that advanced syphilis only affected Black people's hearts, and it affected white people's nervous systems. And the thought behind that was because Black people had such primitive nervous systems that it was unlikely that the infection would affect their nervous systems. And just to say that actually became the basis for Tuskegee study to see the sort of natural course of syphilis in Black people and to see if that could be proven. Even when we look at sort of medical practice during slavery, it was really a medical partnership between the slave owner and the doctor. Physicians, again, were charged with establishing the soundness, quote unquote, of enslaved people on the auction block. When enslaved persons became sick, often other enslaved persons were responsible for their care using treatments that are passed down over generations. But if those didn't seem to be working, often the slave owner would bring in, would try their own remedies, would also bring in a white physician, and usually tried remedies that were not very acceptable to enslaved persons. They were very primitive. They were involved like lancing and bloodletting and purging. And so these were often seen as very sort of torturous treatments. And if that didn't work, the slave hospitals were places where very sick enslaved persons were taken, and they were often sites of torture and abuse. And so we know that medical experimentation of Black people has been occurring over the centuries. I think the audience may be most familiar with J. Marion Sims, who's the father, a quote unquote father of modern gynecology, who himself owned people and really practiced and refined and perfected his surgical methods on enslaved Black women, obviously without their consent, without anesthesia, techniques that were then used only for white women. So this is all part of the history. We know that, for instance, Black bodies were often taken from graves and cemeteries for use in medical schools throughout the country. And then just moving to more current times or last few decades, when we think about segregated hospitals, there were often places where Black people could not get care, for the large part of our history here in this country. And we were not often allowed into white hospitals. If we were allowed in, we often had to consent to being experimented on in order to gain entry, or had to wait until all white patients were taken care of. So just to say that the care of Black people by the medical establishment has always been secondary and an afterthought. And I think this, when people know about this history, and a lot of it can be passed down through oral tradition, this can obviously influence our own experiences with the healthcare system. And just to say, I wanted to mention the difference between mistrust and distrust, just in context. So mistrust refers to just like a general unease and uncertainty or lack of trust that's not necessarily based on experience. Whereas distrust is a lack of trust that's based on someone's own experience or reliable information. So just to say that many people may not have necessarily experienced all of what I've talked about, but they have current day experiences and that have developed in them, and so have created this distrust or mistrust that they feel.
I'd like to add a little bit to this, because I think it's also, it's so important, that history that you're sharing. And I think many people from different backgrounds have had other stories, Native people, Latino, we all have these stories that have created that layer that I spoke to before, of adding on top of, just if we think about medical mistrust in general, that everyone might have, no matter your ethnic or racial background, but what then gets added to it. And for me, it's also about the reality of medicine. Medicine is not an exact science. And, as a psychologist, I know that what keeps beliefs going or behaviors going is intermittent reinforcement. And so unfortunately, medicine as a field is by nature a trial and error field, which means that we're going to assert knowledge and assert truth that will later become a lie, because it has to do with how much we know at a given time. A lot of experimentation these atrocities that were done was, we didn't know how the body worked. There hadn't been actually anyone who had opened up a body. There were different things that we were learning over time, and how we learned, is the atrocity of who was then used for those experiments. But I think it's also important to recognize that this issue is an ongoing issue. We had it in HIV. We started giving messages out when we didn't know exactly how that virus was transmitted. And so we lost credibility really early in that particular situation. And in some ways, we've given medicine a status that is causing confusion, because at least in my family, there was this love-hate situation. Like the doctor was God, and whatever the doctor said was right. And then on the other side, my father said, never go to the doctor. All they do is tell you what's wrong with you. So, so I also want to just recognize that, because I think that we need to keep thinking about how we get a healthcare system to acknowledge that they're imperfect, and therefore not create sort of just the sustained lies over time. With every new discovery, we have to, redefine what's an appropriate treatment, what's this, what's that, what really works. And that is something that's adding to this mistrust over time.
And just to piggyback again onto what Dr. Gomez was saying, like I think also particularly within the healthcare system, there's this power differential, right, with the physician or the nurse and the patient. And the way that it's taught in medical school is that, the physician knows everything, right? But the patient is really an expert in their own illness and their own personal experience. And I think until we get to, have a therapeutic alliance which recognizes the expertise on each side, I think also like this power differential also helps to engender this mistrust that people often experience.
Yeah, and then I like what you said about that, because it's also important to bring in people's culture to that and how their families have addressed things, and because you're bringing your whole self. And so when medical providers can be in partnership with their patient panel, as opposed to coming in this more power over way of directing the healthcare, I think that's on the road to rightness in terms of diminishing the mistrust or distrust that patients may feel, especially when there's some kind of racial ethnic difference or any type of discordance in the relationship and based on the individual. That you could address those things there by listening.
Mm-hmm.
Mm-hmm.
This is so powerful. I just want to call in the really amazing comments that are coming in from attendees about how powerful this conversation is. I want to read this very briefly. I appreciate this authentic conversation and that the panelists are bringing multiple perspectives to bear in the conversation around medical mistrust and professional practice, such as an individual, an academic, and a researcher, etc. And so I just want to have that as part of the record, so to speak, because it's so valuable and beautiful and raw what is happening. One of the calls to me of this time is to really learn about that history. And so thank you, Dr. Blackstock, for giving a high-level overview, particularly as it relates to Black bodies. And so I think one of the calls is on us to really deeply learn, as you reminded us, Dr. Gomez, of the atrocities that have been committed historically, that have been left out of many of our trainings and are not part of the public knowledge from which decision-making is made. And the other thing that I want to point out and then ask the question is that even when we do begin to acknowledge there's a history, it's as if it's in the past and it doesn't connect to who we are today and how we got educated or what jobs we have, and then the power differential, Sean, that you just brought up. And so I would like to have a bridging here for a moment between how are those historical facts present in the day-to-day practices. And Dr. Blackstock, if you want to start again, and then we can kind of round robin and riff off of each other.
Yeah, no, I think, many people are familiar with Tuskegee. I'm also happy to name a number of other incidents that affect different populations. But I think, people also know how their family and friends are treated every day. I think Sean spoke to this, within the healthcare system as well as outside of the healthcare system, and how those interactions have really eroded trust. I was actually just thinking, I have a 7-year-old, and a few years ago he broke his wrist, and we went to the hospital, to the ER, and the orthopedist, who was a white man, actually adjusted or manipulated his wrist without any pain medication. And I wasn't and it happened so quickly, I couldn't then do anything. But I became more familiar with the literature on differences in pain treatment when folks show up to the hospital, and this is specifically looking at Black patients versus white patients. But Black patients who come in with similar injuries, similar like pain rating, are much less likely to receive pain treatment. And if they do, they're much less likely to, the dose that they get is much less than a white patient, and that these same differences are seen among children, Black and white children, when they come in for appendicitis. So, you know, we also see differences in the way that providers talk to people of color. For instance, there tends to be a more dominant communication style that healthcare providers have with Black and Latino and Indigenous patients. They show less emotion, like positive emotions. They are less often to request the patient's input. Like all this has been documented. So just take away the history that we know about just in people's everyday interactions, they are getting the message that they do not matter when it comes to the interactions with healthcare providers. So that's just the individual level. And just to say also, many people of color, Black and Latino, Indigenous people live in areas where the hospitals and clinics that are serving them are often very under-resourced. And so people, again, maybe they know that the quality of care that they're getting is somehow different from the care that other folks are getting.
And you made an important point about that, how Black folks are treated differently around pain management and tolerance of pain, and all of those types of stereotypes and myth comes back from that history you talked about at the beginning, where they would talk about we had thicker skin, or that's why they were experimenting on the slave women in that way without the anesthesia, where they can tolerate the pain. And that raises one of the biggest stories in my life, a personal story I'll share because I think it's important, is my sister has many complicated health conditions. At the time she did, but she was presenting at I won't say the name of the establishment, but the managed healthcare facility with pain, and they thought she was drug seeking, and she has no history of anything like that. She's a regular old Black Christian woman, if that makes sense to you. But yeah, and so they sent her away, and she would continue to complain of the pain. And how what this culminated into is my sister ended up having had some sort of blood clot drop down to her leg that was causing this pain, and she didn't know what it was, but the pain medication they gave her, she continued to take it, right? And I noticed that when I was talking to her, because she's in Los Angeles, I'm in the Bay Area, that her presentation was off. And I was in LA, and I said, I'm coming to see you. And when I got there, I was like, something's wrong, and I called the paramedics, and I had them come take her to the hospital. And what ended up happening is my sister lost half of her leg, because her leg had basically died, and she was on the verge of becoming septic, would have died literally. Maybe a day or two, she wouldn't have been here to live through that. So that's how these types of thoughts, and why I think providers really have to work on those biases, and you need to have these unconscious bias trainings ongoing. It needs to be discussed and incorporated in policies and procedures in healthcare institutions for this change to happen. We can have this discussion, but if we have to really get to how we can change people's thinking. Like maybe it should be mandatory reading for Harriet Washington, because that is a powerful book. It was for me, and I was not a good patient after reading that, because anything they were trying to do to me, I'd get an x-ray, I'd be like, no, how much? Because they would x-ray us with more of whatever, I forgot the name of whatever, the Rogons or whatever the thing is that they x-ray you with, that they'll give you a higher dose versus other people as they were trying to find the dose. So many of the things that we go to the doctor about and experience with majority comfort, not that it's comfortable get a Novocaine shot, but believe that people suffered so that you can go in and get that little pinch in your cheek or your little pinch wherever it is. And most of those people that were suffering were Black and brown and Indigenous people.
Yeah, and I'll add, I think that I'll give a shout out to those who are listening from Boston. I started my work as a outreach worker at Upham's Corner Health Center in Dorchester. And one of the things that was so important about the providers I was surrounded by, who were very dedicated to the community, was also accepting people's beliefs. So we worked a lot with a lot of people from the Caribbean islands, all different islands. And there were very strong beliefs around the spiritual contribution to one's symptomatology, and the importance of understanding that the art of healing. And I felt the providers I was with really understood the art of healing. It wasn't just about treating symptoms, but about understanding what the patients were complaining of and what their belief system was. And I actually, part of my job was to go out and meet the healers in the community. We're mostly curanderos and other type of healers who had a very specific belief that certain symptoms were representing maybe a family who had passed away and had unresolved business and needed another human, an incarnate, if you will, to assist their soul to be able to be released. And so they would have a paralyzation, a paralyzed arm that had no medical explanation. And it was really the curandero's job, for example, to say to them, oh no, this isn't spiritually based. Go see a regular Western doctor. You broke your arm. But it was also beautiful to see our providers be able to say, you know, this is not a medical problem. You should go see your curandero. And I think that's what we've lost. We've lost some of that authentic willingness to accept people's beliefs and how much their beliefs will influence our physical being and influence our symptomatology. So some of that is just really in practice today. We've gotten so prescriptive and so, you know, algorithmic and thinking about health. And I think that's what some of the ways in which we've lost the trust of those who seek health care of any kind.
Yeah, I agree with Dr. Gomez, and I think it's so important also to like hold space again for people's beliefs, but and also counter narratives. Like, you know, like if they're, you know, if we do have patients coming in who, for instance, you know, are concerned about the COVID-19 and they're taking various, you know, herbs or whatever it is to stay safe. Okay, like, you know, as long as they're safe, it's great. Do that, and we can also do social distancing and mask wearing and everything. But I think it's so important to like recognize and acknowledge the efforts that people are making to stay safe and, you know, whatever their beliefs are, and how we can also just add other helpful information that also benefit them.
Yeah, and I think Sean mentioned earlier the importance of how to advocate for yourself as well. And I you know, again, I myself, you know, with all this background in health, you know, once you're a patient, sometimes you lose all that when you walk into the doctor's office. And, you know, my doctor recently retired, and I thanked her because she helped me with a medical issue I was having. And she said, oh no, you know, you came to me and at first I said, no, it was nothing. And then you came back to me 2 weeks later and said you still thought it was a problem. And she said, don't lose that. Don't lose emphasizing to your providers what you need, because sometimes, you know, we just take for granted that we know what's happening. And it's really, as a patient, the individual needs to keep advocating for themselves. It's unfortunate that we have to do that, but I think critically important to establish, as people said before, that partnership. You know, we're shifting from patriarchy to partnership when it comes to medical interactions.
Yeah, thank you so much, all of you. And I totally also want to really recognize, you know, as someone coming from outside the healthcare industry, hearing some of the stories, especially of your son, Dr. Blackstock, and of your sister, Sean, those are tragedies and horrendous. And I can only imagine what it's like to live through that through a personal lens. So thank you so much for sharing. And I do want to take a second to, you kind of mentioned this a little bit, Dr. Gomez, of how really kind of naming things and the collaboration that's needed. And I love that the switching from patriarchy to partnership. I think there's a lot of power in how we discuss things and how we give them names and the terminology we use. And I'd love to know, in your work at the national level, how is really defining those terms serve to set the stage and kind of chart a new course around collaboration, patriarchy, dismantling it, and creating partnerships?
Sure. You know, that we've really changed a lot of our language, I think, in the last 40 years at least, and it continues to change. And I think it is important because it matters, right? Words matter. And so a couple of examples that I'll give has to do with even the sort of models that we've used before. So in healthcare, our traditional medical model really started with sort of individual behaviors. What are you doing to cause the illness or the problem that you have, right? It was really about the person's blame. What are they doing? And then we understood that, you know, as we started to learn about genetics, there might be something influencing there. But really it started with what, you know, what did you do? Or what are you not doing? That's going to lead, you know, to poor health outcomes. And, you know, that was a traditional medical model. We've moved from that, luckily, into the much more socio-ecological model, where we're recognizing that there are antecedents to that behavior that may not be the responsibility of that individual. If you are not allowed to have access to good education, to good housing, to good health care, you don't have a fair and equitable way to access it, you know, that's what's causing it, right? That it's those injustices, those structural inequalities that are doing that. So when we started to shift from that individual focus to this broader focus, I think people started to understand that not everything is free will. You know, you don't always have a choice. And, you know, I think, again, people had to recognize this in a way that was starting to help. We then moved to social determinants of health, which, again, has been slow in coming, but, and people are trying to understand what that means and how we might intervene. But it's the same idea, right? That there are other factors that are contributing to our poor health. You know, the fact that certain people, particularly Black and brown people, weren't allowed to own houses in certain areas that have much better environmental conditions. Well, then why are we blaming individuals who were forced to live next to refineries, next to chemical exposures for their health outcomes? So those changes were really, really critical. You know, I think, you know, these kinds of changes are helping us think differently from the individual blame to the social responsibility. So those are some of the changes that I think are critically important.
Yeah, just to also add, you know, and I totally appreciate what Dr. Gomez was saying, and there's been like the emergence in the last few years, at least in medical training and education around structural competency. So like this shift from cultural competency, which seemed to be really focused on almost stereotyping different groups of patients and, you know, what their expected reactions might be to, say, having pain, to cultural humility, which was sort of like, you know, this recognition that we're sort of lifelong learners in terms of learning about our patients and their communities, and then moving to structural competency, which is really what Dr. Gomez was talking about, really understanding what are the structural drivers of the social determinants of health, also called the structural determinants of the social determinants of health. But I think until we have healthcare providers really understanding really the policies that constrain people's choices and that result in certain behaviors that then get labeled as unhealthy, like we have to have an understanding of those. And also, you know, many of us are in a position to advocate, you know, for our patients and their communities to speak out. So just wanted to just emphasize that, and the role that healthcare care providers can play both within healthcare settings, but also outside.
Yeah, and one more thing to add is, you know, I'm very happy to say that I was sitting on the Federal Advisory Committee for Healthy People 2030, and I'm really, really pleased that the way that Healthy People 2030 is being set up now is with a health equity lens. And it's very important because it's basically for any health outcome that you want to look at, the question you have to put is, what are these determinants of health, and how do we acknowledge if there are disparities or inequities? And let me define that for you. So health disparities was the term we used a lot just to say differences. And for a while we meant racial and ethnic differences, but it really was without explanation, sort of just health disparities was differences by groups. Health inequities, we now understand, is when there is an unjust and unfair reason for those differences. You know, when I founded the Health Equity Institute, people asked me, oh, you mean health disparities, right? You're talking about health disparities. I'm like, no, we know there are health disparities. I'm talking about solutions. Health equity is about solutions. So I think, again, changing terminology like that is really key in helping us continue to acknowledge how health outcomes can be addressed. And again, this new lens with Healthy People 2030, I'm excited by, because it's going to basically structurally ask people to be looking at it that way, which we hadn't had before. We had it, but in softer terms.
This is all so valuable. It's hitting two things for me that I want to bring forward. One is how important it is that we understand the words we're all using, and the value in being able to have these new words to talk about these nuanced layers. So I just appreciate being in the conversation with you and the prep work that we did for this, right? Really going back and forth about what does this word mean to you? And it occurs to me like how important that is to do it in our day to day. Also, I'm part of this working group where we're working on putting in a consensus statement. And there's been quite a bit going back and forth about some language and kind of two different ways of thinking about some language. And as I was thinking about this portal, this liminal space that we're in, I realized there's also this awkwardness that happens when we realize old structures are crumbling and falling apart, and we don't yet know what that new place is where we're going. And so I want to call that out too, that one, for us to develop some comfort with the awkwardness of not knowing and being called out or called in on words that we use, and that there may be, we're going to be practicing as we figure out what it looks like to confront anti-Blackness and dismantle white supremacy, the new words that we're actually going to use. And also as we grow and we get more expansive about gender and how we build families and all these other wonderful things, that there's going to be new words that evolve. And that's to me, part of being in the work too, is sitting in those awkward spaces and giving and receiving feedback, and then trying on new words and seeing how they land and how that helps to communicate and bridge with folks. So thank you all for that.
I have a new word.
Tell me.
My new word is not to refer to Tuskegee as the Tuskegee experiment, but as the U.S. Public Health Service syphilis experiment at Tuskegee. And words are powerful, because when you think of it, that's a HBCU, right? That's a Black college, and you know what it is. If you just say Tuskegee, oh yeah, that's where they let the Black men just die from syphilis because they were experimenting on them. And that wasn't that long ago. That only ended in 72. So that's my lifetime. And everyone's lifetime, I think. I'm not going to try to age anybody on here, but on here maybe. But yeah, I think that is important to me. I never call it the Tuskegee experiment. I'm a Black Studies major too. I'll just say that for undergrad. So I'll never call it that. It is the U.S. Public Health Service experiment at Tuskegee, syphilis experiment. And that's important to me because it was the U.S. government that authorized and perpetuated this atrocity on this community. And so that's one for people to take back with them. Here, I'll share that one with you.
Thank you for that teaching, Sean. I appreciate it. Mm.
I think that's so powerful. I know I appreciate that point. And I think about, at the same time, there were also quote unquote experiments around syphilis going on in Guatemala, right? Among people who are incarcerated and mentally disabled, but we don't call all of what happened, the US government's experiments, but I think it's important to call that out. Mm-hmm. Thank you.
I'd like to build on a concept you brought forward, Dr. Gomez, which was about honoring people's beliefs. And this is actually going back to something I learned from Dr. Blackstock a few months ago when I listened to one of her wonderful presentations, where she got to really spend probably 45 minutes or an hour talking about the history of medical mistrust. And you really reframed it as a resilience practice. And that felt so important to me, because I think, one, we still have to hold the space of what it grapple with our complicity in a structure that's not trustworthy. But it's also very different when I then think about how I can bow to or honor or believe and look as medical mistrust as a practice of resilience. And so, Sean, I'm wondering if you want to start us off for this part of the discussion, which is, how is it that we can reframe medical mistrust as a protective practice?
Well, yeah, it is a protective practice, especially I can only speak from my experience as a Black man in America. And any ways that I can protect myself from racism and anti-Blackness, I do, because it's pervasive. It's all I got to do is wake up. I got to open my eyes, read the news. There's anti-Blackness. We just had a whole federal administration perpetuating anti-Blackness, anti-Brownness, anti-queerness, where my whole identity has been under attack. And I can't tell you the relief I'm feeling that something different is on the horizon, because I don't know how I would live through the opposite of that. And so it is resilient, and particularly from a trans experience. Trans folks don't want to go to the doctor because the medical field is not equipped to deal with us. It's like I have to go into a provider appointment and educate my provider. But if I go in for diabetes, my expectation is not that I'm going to have to educate my provider, and it shouldn't be. You know, we need to have spaces where we're going to feel safe, where we're going to feel welcome, where we're going to feel cared for. And then when you look at intersectionality with trans and trans people of color, then you have all of the, the structural racism and anti people of color, indigenous people coming into that. And so sometimes it is a first step to go to your auntie or your grandmother and say, hey, this thing is going on. Because my grandfather he used to tell me wild stuff, like, and I laugh about that now, but some of those things I do now. Like, I very rarely get colds. I'm not the guy that's going in for a cold. I have to have something really going on to go show up at the medical clinic. But when I do show up, I want to make sure that the person that is there is able to treat me and treat me fairly, and I don't want to be afraid. I had one experience where I had an issue going on and I was referred to the breast cancer center. And I cannot tell you, I hadn't transitioned yet, but I was very gender nonconforming. And when I showed up at this breast cancer center, I can't tell you the relief I had when the first person I encountered was a nurse practitioner and she was a lesbian. I was like, okay. But when Dr. Evans walked in, it was a Black woman. And I said, okay, I'm going to be all right. I'm going to be all right. Dr. Evans going to take care of me. And it did pan out to be okay. But I think that's just important, thinking about, the medical establishment and how do we diversify that in addition to these trainings and ways that we are continuing these discussions, because we can't just leave it here.
Dr. Gomez or Dr. Blackstock, would you like to add to this thought or conversation around it being protective practice or a resilience measure?
Absolutely. I'll jump in. I mean, I think that it's critically important that we, see ourselves as assessing whether these are safe spaces for us, for all the different types of interactions that we might experience because of all the isms that we encounter. And so we're evaluating that regularly. And I think that is protective. And, a lot of people don't feel they have that power, though, as we talked about earlier. And I think that's something that we need to work on, is how do we help people feel that they have, again, that power in that interaction, because it is resilient to not accept being treated poorly, being treated unfairly, unjustly, and doing it in a way, though, that is also showing that we're above perhaps some of that. I think we've seen too much of the um, ways in which it's done during these last few years, as you mentioned, Sean, under this administration, has just been mean and cruel. And in a healthcare system world, again, going back to my comment about healing, it is about healing, and healing has to be holistic. It's not just my physicalness, but my soul, being able to feel safe. And so for me, those changes happen at the receptionist, right? Not just the providers, but the moment you walk in, is it welcoming me? Do I see other people that look like me? Do I see messages that seem not just for some people? Am I going to be accepted even if I were illiterate? There's just a lot of little things. I mean, many of us in other venues have talked about the medical forms and how much it took us to change that, to even have, for example, other genders listed, to have, not have to say if I have a husband, that I could say I have a wife. So all of these things matter, these little things that make such a difference. And so I think that resilience is really about letting people know when you don't see yourself in what people are showing you, and that's not a space for you if you're not going to see yourself there.
Yeah, and just to add on, this mistrust is a survival mechanism. It does allow individuals to prepare like countermeasures. So like if I even as a primary care doctor, I don't like going to the doctor. But I do make sure, and I do tell my patients when they're going to see other providers to like get as much, look up as much information as possible. I try to be a resource for them, have a family member or a friend go with you so they can also advocate for you. I think there are different strategies that can come out of this mistrust that can be beneficial and helpful in terms of preventing harm and getting the care that people need.
Thank you all so much. This has been incredibly illuminating, and I want to slowly move us over to the Q&A session. So also, if people have questions, please make sure to drop those in the little Q&A button at the bottom. And I do want to take a second just to kind of call in how much the system itself sort of plays in, and you've mentioned that a lot, Dr. Gomez. You mentioned that, Sean, in terms of how the system, there's so many systemic issues here at play. And I know that I think I personally am super like, how do I make it better, right? What can we do to move this forward? And that's going to be the topic of next week's panel. But I do want to open it up for questions. And Oni, Dr. Blackstock, you really kind of got us started on this idea of potential solutions that we can do at least on the local level. So thank you so much for that. And I'm going to pass it over to Shannon to get us started with the Q&A portion.
Yeah, great. Thank you for that. So what I'd like to do is take a comment from David Malebranche in the Q&A, as well as something that came through in chat earlier, and then kind of meld these two together for a question. So David has said, not a question, but a comment. Dr. Kimberly Manning published a narrative in Lancet earlier this month about how she felt as a Black physician, graduate of Tuskegee, participating in COVID-19 vaccination study trial. Tuskegee is an HBCU, not the study itself. Sean is so right. And so thank you for that. So then I want to add this to this comment that I kind of took a screenshot of earlier, because I was like, this is so important for us to hit on. I also wish to name what it means for us as healthcare providers to witness and be traumatized by the abuses committed by doctors and other healthcare providers, and how hard it is for us to work against the abuse and mistreatment perpetuated by our system and colleagues. And people have appreciated that we're looking at this through multiple lenses and multiple hats. And it seems like from the comments, there's lots of healthcare providers on that this is resonating with. I've seen this prior to COVID being talked about in terms of not burnout, but moral injury. So what is that ongoing? It's also called secondary stress trauma, vicarious trauma. So there's a number of names for it. I wonder if we can talk about that for a little bit, about what is that impact and potentially strategies for mitigating that through the intersectional lens that you have. Who's feeling it?
I mean, I'll just start with some initial thoughts. No, I agree with the commenter. Just in terms of like the culture of healthcare and medicine is incredibly problematic in so many ways, and I think sort of feeds into this. I think also compassion fatigue. I think I've heard the term used, and I have to be honest, I'm a little less familiar with like the literature on evidence-based strategies to address compassion fatigue. But I assume it has, I'm sure it involves mindfulness, taking time for oneself, various check-ins. I don't know, but I just want to like agree with the commenter that the way the system operates, the rush, you're rushing in and out to see patients. You don't have a lot of time to spend to even just be a human being. By the time you ask, how are you, how are your family? It's like 15 minutes into the visit and you've only been given 15 minutes to see your patient. So I can see in so many ways how the way that things are currently organized can engender this mistrust and make it difficult for providers. I don't I don't offhand know of strategies, but I think though also having spaces also for providers to acknowledge this and recognize this is important, and to also to normalize. I think there may be some level of shame being part of a system that is so broken. And so I think opportunities, I think for healthcare providers to come together to support themselves, but also there have to be obviously systemic changes
Right.
that allow providers to really take time for themselves and for their patients. But it's a capitalist healthcare system. So.
And I would add, I mean, you know, if you're already in the system, it means that you have overcome many challenges as a person of color to actually be a doctor or be a provider. And I think that you're put in a position to tolerate more than you should because of the power differentials, because of the risk that you will, you know, all the things that get in the way, the old boy network, you know, and so if you want to take that risk of witnessing things and then how to address it, how to call it out without jeopardizing, you know, your own livelihood and reputation. And it's again awful to be put in these positions. And you know, for most of us, we're very few in numbers when we're in these settings. So it's also about how do we get enough allies to actually be the ones to call out when they see these things happening, and not expect the providers of color to be the ones to have to do it. I mean, I think that's also part of the issue here, is, you know, if anything, it should be others, and that we are protected from that.
Yeah, I just think it's so many layers to that question, and so many things come up for me. I'm not a doctor, I'm not a clinician in that way, but I've done direct services with poor people accessing care at community hospitals, and I have watched how care is delivered or not delivered, in my opinion. You know, I've had people that have very serious health conditions and have to wait to get an appointment 8 weeks out, but you have some rare form of cancer and you're suffering with mental health and maybe substance use issues. And that's where the question landed for me, and how frustrating it was for me as a care coordinator, right? I would take these people to their appointments and advocate for them with their clinician for medical care that was non-existent in this public forum. And that it was horrible. I hated that job because I felt like uh, there was nothing I can do. I took the job to help people or support people, but there was nothing I could do. What I finally came to the conclusion of was that I was expected to teach people to live in lack, abject poverty, and to accept less than they deserved. And that's very frustrating. And it does require some mindfulness and also some movement to figure out, well, how can I get further upstream so that then maybe I can affect what's going on this way with these folk. Yeah, that's a deep question to me. Yeah.
That's big. There's some excellent questions that have come in. And what I'd love to do, if Lisa, if you will help us, is have some folks come off mute. So Caleb, I see your question. I love it. I'm going to prioritize going with Jim and then Jennifer and then Rupinder, because I think that they get to the nuance of what you're asking. We can loop back at the end, Caleb, to see how we've done with your question. So Lisa, if you could go to Jim and bring Jim off of mute, that would be great. And Jim, if you could bring your question to the panel, please.
Thank you so much, Shannon and everyone. This has really been an amazing panel. I'm just blown away. And this is really picking up on something that everyone said, and I know Dr. Blackstock just mentioned this capitalistic system. And so I'm going to try to tame down my question. I'm talking about burning things down. I'm going to try to calm myself down a little bit. But you know, to your point, the system is set up so that people can't be their best selves. A doctor who has 10 minutes to see you can't be empathetic and listen to really know who you are. They come in, it's short, it's brutal, it's often very nasty. I, as a white cis guy, have experienced that. I can only imagine how much worse it can be. And I can't imagine how bad that is. It's really terrible. So the system is set up, and this capitalistic system is set up to hurt all of us. So what is a step that we can take to start dismantling the system? What can we do, whatever space we're in ourselves, to start to change that? Shannon earlier talked about this portal. And are we going to drag a bunch of garbage through this portal that the pandemic is? Or are we going to leave some of, I would like to leave some of it behind. What do you think, what maybe can we start thinking about doing from our individual selves, and maybe if we have organizational connections, what we could do in that space? Thank you.
Thank you, Jim. Who wants to jump on that?
You got to change how change is going to happen, and you might have to burn some things down, Jim. I mean, if we're going to get something different, because if you want to burn things down, reach out to me, because I'm down with the burning it down, because this doesn't work. I mean, I don't know how many ways we're going to flip it and turn it. It just doesn't work. And so it is going to require some accountability from institutions. The institutional, I'm going back to the dimensions of cultural humility, because I practice that in my work, in my life, and I believe it. Is you have to address those imbalances. You have to hold the institution accountable. Are there policies reflecting what you are setting out to achieve or not, right? Are the staff there reflective of who you're serving, so that we can have less, more than 2% of, for me, less than 2% of doctors being African American or Black? How about that? Or what about some queer and trans doctors out there too? When I show up, I'd love to have a trans doc. I have a great provider. They're not trans, but they're very transliterate, and they're, top of the field around that particular specialty. But yeah, it has to just change, and it has to be people like you and everybody listening that's saying, hey, we want to change something. You are the change. You have to step up. You're gonna have to risk something, because when you're talking about these lives of the people who are most impacted are Black, Indigenous, and brown people, right? Poor people. It's going to take those people in power to say no. So if Black lives really matter, and all that chanting and walking down the street really mattered, we have to put that into policy. We have to put that into action, and we have to hold the people that are currently holding the power accountable to this change. And I think what my hope is, I mean, I still know 70 million people voted a certain way. However, I'm keeping hope alive that the majority of folk can go out and make and affect this change that we say we want. We have to. Because if you're tired, imagine how people who aren't white cis men are feeling.
Yeah.
Yeah.
Go ahead.
Oh, and just to add, like, there are, so many organizations. I'm thinking about just health. We were talking about the healthcare system and the way that things are currently structured. So just in terms of thinking about healthcare for all in a single payer system, there have been folks who've been working on this, for decades, who are still pushing for it. And so I personally am heartened, working side by side with these individuals in terms of thinking that we can have like a different future in terms of how we, ensuring that all Americans have healthcare. I also think about like the Young Lords. When you talk about Young Lords, didn't burn anything down, but I just think about the Young Lords when they occupied Lincoln Hospital in the Bronx, and just really pushing there. They had like a list of demands, and some of them were around having a governing board that included, both residents from the community as well as staff from the hospital that had, weren't just there to speak, but actually had power to inform the agenda for the hospital, the budget, all of that. They actually pushed for the first known patient healthcare Bill of Rights. So I think we need to start, we're not like pushing these hospitals, these healthcare systems to do a whole lot. And so I think we can sort of take lessons from the past, from the Young Lords, even from the Black Panthers, who were able to, provide healthcare in a really, simple, low barrier, but innovative way, and just think about how we can do things differently. Like Arundhati Roy was saying about this, we don't want to return to normalcy. We want to change things up. So just knowing that there are folks who are working on a new world, and we just need to also just like donate to them, work with them, do whatever we can to support those efforts.
Yeah, I would also add that, through policy, we can change the incentive system. Right now, the incentive system for most of these privatized healthcare systems is profit. And I think that needs to be shifted. And, allowing companies of any kind in a community should be with certain conditions in terms of how they're contributing to that community. How we measure improvement in the health of our community should be a report card of those healthcare systems. And the incentive should be that they have to meet a certain qualification to exist in our communities, even if we're not changing the profit margin that much, but changing the incentive. Because right now there is nothing, as you say, there's nothing that's not going to stop them from continuing to reduce the number of minutes you're allowed to have with a patient. I mean, those are the things they're using, right, to qualify their docs. We need to change what that measurement is, not only for the provider, but for the system, and make those into policies that really matter and that are really held accountable.
Great, thank you for those responses. So much, and so much we can carry forward to next week too. Also some of the awesome questions we've had submitted. So I wonder now if we can go to Jennifer Rubin. Hey, Jennifer. Jennifer, are you there?
Yeah, I don't know if you can hear me.
Now we can. There you go.
Perfect. My mic's pretty quiet. So I'm listening here in Chicago as a pediatrician, but I'm also the chair of our review board, our institutional review board for our hospital. And I'm wondering, we've talked a lot about clinical care. I'm wondering if you could speak about what research can do, what we can do to improve mistrust as it pertains to study participation and access to studies. We obviously need to acknowledge historical and current racism, but also making sure we make these studies equitable and accessible to all.
Absolutely. I'll jump in here. You're probably familiar with PRIMER, Public Responsibility in Medicine and Research. I had a chance to serve on their board, where we work a lot on ethical issues and how to create protocols that really are transparent and are not going to stop anyone from being able to understand why they are or not participating. For me, a lot of the work that I've done as a researcher is community preparedness in terms of how the community is going to learn about the study, what the study is for, why people should participate, how they will benefit or how not, how their community might benefit. So that building phase, I feel that many researchers do not do that, even if, and I don't mean just behavioral science, I'm talking about basic science at all levels, is how to even inform people that the study is going on. Number one, as you may know, it wasn't until recently that we had to change the federal guidelines to require researchers to include women and to include people of color. So I think that we really do want to think about everyone on the team. Who are they interacting with? And then what happens afterwards? Do they ever hear from you again? One of the things that was so critical for us was to always keep our participants updated on where we were in the study, how much longer we thought it was going to go before we could give them results. And then to create not just those papers that we want to publish, but we would create these, what we called 4-pagers, because that was approximately how long they were, a very clear sharing of what we learned from the study. So really thinking at all stages, recruitment, all stages, how are we ensuring that people can learn and trust what you're doing. And for us, that really resulted in very positive interactions. But it only takes, one colleague, another study to get a whole community to say, no way, we're not going to do this. So I think holding our peers accountable as well is really critical.
Yeah, and just to add, I think that co-creation is a really important part of buy-in and gaining trust. So, obviously community-based participatory research is obviously the ideal, but I think the way that, academia operates and funders operate, we often don't have the time to really start at understanding, what matters to the community as opposed to what's the matter with the community. But I think we need to, ideally, that would be the best approach, is really starting with what what does the community feel like they need, what are their assets, what do they have, and going from there, as opposed to taking our questions, bringing them to communities.
Yeah, beautiful. Thank you for that question, Jennifer. Can we go to Rupinder? Hey, Rupinder.
Hi there. You can
Did
call
I
me
say your name correctly?
said it beautifully. You can call me Rupi. Thank you so much.
Hey, Rupi.
So first of all, thank you all so much for just doing a really masterful job of blending your professional expertise with your personal experiences. It's incredibly powerful and impactful. My question that I presented was, I do believe training is important, but feel strongly that accountability and reporting have to be implemented. I should also say that I'm a child and adolescent psychiatrist, also an adult psychiatrist, where there's so much room for abuse and mistreatment. And I think your stories really reverberated with me. So what I wrote is, most academic medical centers and healthcare institutions will never announce or report the racism, misogyny, and oppression they actively engage in, despite how damaging it is to patients and their families, and also how damaging it is to each of us to witness this, be a part of it, and then be frozen when it happens. I wondered what you all see as the role of accountability and reporting vis-a-vis abuse and mistreatment leading to mistrust and distrust, and how we can think about successfully putting it into place, recognizing that it's also directed towards our students and healthcare providers.
Dr. Glockstock, you want to get started?
Dr. Gomez, you can go. You can go. You can go this time.
No, I was just going to say, I think we do have to do that. I think accountability and transparency is just lacking, right? I mean, I find out more through Nextdoor, the app, about something happening at a healthcare system in my community, not because the healthcare system's ever going to, acknowledge, what they're doing. And so I do think it's about, I think of it like family, right? In your own family, how do you make your family accountable for what they're doing or how they're behaving? How do we raise our children to be accountable for what they do and what they say? And we're not doing that in our systems of care. How is that possible? So I think that it's definitely something that needs to be done, and we need to find the right way to do it. It's not meant to be, necessarily a shaming or people being afraid that it's going to come across in a way, but it could be, just a combination of both clear expectations, because I think that's the other thing, is people sometimes feel they don't know what we want from them. And so we need to be able to define that. And that's a fair, thing to just, it's easy to sort of say what we think should be happening, but we need to be really clear about what that is, and what does it look like when it's not happening correctly, or it's abusive, or just completely unacceptable. So I agree that is something that we should really be asking more from our systems of care. And it does start with the medical schools. I mean, I certainly, while at UCSF, I mean, medical students themselves complained about some of the teaching they received, some of the bias of what they were being taught, some of the stereotypes that they were already getting through their education. And I think, again, because of the activism of students, we've seen a lot of change in curricula and how, removing some of that bias and really privilege out of that curriculum as much as possible. So those are just my immediate comments, but I'm sure others can add.
Yeah, no, I totally agree. I think there also just needs to be like a reckoning, like hospital leadership. We have a lot of these healthcare systems that are like nominally nonprofit, but they have boards, they operate like for-profit systems. Their incentives are, not really aligned with those of values of the community and the patients that they see. So, I mean, I think until we have folks who are leading these healthcare systems, CEOs, boards, really prioritizing, creating a culture that is equitable and inclusive, we're not going to see a whole bunch of change. And I think, I think, it could be, for instance, healthcare systems get reimbursements based on, having less people, people not come back to the hospital after their discharge, or not get urine infections when they have a catheter. And, I think this is maybe a little bit related to Dr. Gomez was saying before, like, how can we incentivize, like, also good behavior? Like, I think setting the expectations is important, but also, like, if metrics around various inequities were also used in terms of like reimbursement for hospitals, I'm sure we would also see a change. So I think there are like systems level and policy things that can also change, but I also think like people, particularly those in leadership, white folk, like they also need to have spaces where they can sit and really work, men, where they work through the sexism that they're perpetuating, white folk where they work through the shame and guilt and anger that they may feel that come up for them with regards to their complicity with whiteness. Like all of that, there needs to be sort of this individual level work that's like happening in addition to systems level, I think, changes that are needed.
Yeah, I don't have anything to add to that. That's it.
Awesome. Well, I'm glad you brought up, Dr. Blackstock, kind of the balance between both the individual and the system level. And so, but I do want to throw to Caleb and invite them to come ask their question.
Hi, my name is Caleb. I use he, him pronouns. And I think my question is, so I come from a public health background and do a lot of work around health behavior. And I think a lot about the different levels at which these like behaviors occur, right? So medical mistrust doesn't just come from individual levels, people's own like identities and experiences, or relational levels, like those interactions with healthcare providers, but also with the interactions with healthcare organizations and healthcare systems and larger like structures of institutionalized racism and sexism and so on. And I think I see a lot in health behavior literature a focus on like, how do we get people to use condoms? How do we get people to not drink or not smoke? And not as much intervening on, like Dr. Blackstock talked about, the social and structural determinants of those health conditions. So I'm wondering if you all could talk about and thinking about like how we intervene on medical mistrust, like the balance of intervening on that individual level versus intervening on interpersonal, systemic, and structural levels.
I'm just going to say hi, Caleb. Glad you could join us. I'll let my colleagues go first.
Well, I think that's, exactly right, that we need to think about all the different levels of intervention. And, as I said earlier, the medical model focused on the individual and what they're doing wrong, rather than on the systems that perpetuate how their behavior is influenced by their context and their environment. So I think that is really key, is how do we go at it in all ways? For me, the solution is first of all, this is a long haul process, right? What we've seen right now in COVID and the broadness of mistrust of science, mistrust of just basic facts. The more lies we get, the less we're going to trust anything we hear. Our technology has moved us to not know what's real and what's fake anymore. I mean, just graphically speaking, let alone the information that's coming through. So I think we need to find the multiple levels of intervention. Certainly at the individual level, we talked about empowering, or not, I don't always like the word empower, but giving people the resources that they need, helping with health literacy. Health literacy is something that we've really not attended to. And it's hard to advocate for yourself if you yourself don't understand how your body functions or what might be options that you might have. And so, those things can be helpful in terms of being a better advocate for yourself. But it shouldn't be questioning your level of trust. Your trust should be earned. And so for me, the system really does go to be the most important. And we do start at that first encounter, whether that be as you enter a provider's office and the receptionist and the lab technician and everyone involved, not just the physician or nurse practitioner or whoever you're seeing. And then of course the systems that are monitoring them and what they're doing. So what are the changes that happen at that level? Because at the provider level or the staff level, you know, again, we talked about training, other things, but actually, you know, Sean mentioned cultural humility. You know, organizational cultural humility is really important, and there are ways to do that. There are ways to ensure that organizations are demonstrating that cultural humility. So I think we need to start at all these different levels simultaneously in order to, I don't know that we've ever been there, but to be in a space where we can recognize, you know, knowledge and truth, and we can recognize a way to build trust that, you know, is not constantly broken.
Yeah, I don't have that much to add to this question. I just think it is a multi-pronged strategy and approach to making the necessary changes to get to the world we want, right? Uh, so I just think helping people learn like the health literacy part, and they're capable, because when I work with people in the Bayview community here in San Francisco, um, they were newly diagnosed with HIV. I was teaching them about their HIV disease and how the disease worked in the body to improve adherence so I can get them to want to take their medication. And I ran my health education groups. And so that's a fallacy that folks aren't able, and many of those folks that I work with probably didn't have a high school education, but it's up to me how I'm going to teach you what type of adult learning strategies am I going to use to get you engaged in that. And so I think that we can get folks to be better self-advocates, but we need to look at institutions, we need to look at providers, we need to look at patients. We have to have strategies for each level of this mistrust. And for providers, just learning, like, sometimes you just got to step back and build the relationship, because the folks have come in already with maybe some trauma, maybe some mistrust. They're not trusting, afraid of whatever their health condition may be or what the outcome they think they may have. Stepping it back sometimes. And I hope we could get away from that 15 minutes with the doctor. I even have a hard time working on that. And I used to work when I was a patient advocate with my clients. You know, I prep them. We're going to get your 3 questions together. What's the 3 top things you want? We're going to go in here. We're going to get these things done. And I just think it's just it's a big job, but I think it's doable if we have enough people motivated.
Well, if that's all the thoughts right now from our panelists, we are pretty much at time, but I want to thank Dr. Blackstock, Dr. Gomez, and Sean. Thank you so much for all of the insight and generosity in which you shared both the literature as well as your own personal stories, and we're all, I think, better off for it. So thank you. I also want to thank Laura Lazar and Lisa Lambert for the behind the scenes tech work here. And I want to invite everyone. I know we didn't get to all of the questions, but we have captured them, and we will be hopefully able to address them at our next panel next Monday, same time. If you haven't registered for that one, please do so. Please bring your friends, and we would love to see you there next week. So thank you again so much, and have a healthy, safe, amazing week.
Right. Thank you all.
Thank you all. This has been so powerful.
Yes. I enjoyed being on the panel with Dr. Blackstone and Dr. Gomez. Thank you so much.
Thanks, Sean. You were great.
Thank you, everyone. Thank you. It's great to meet everyone.
All righty. Bye.
Thanks, everyone. Take care.
Thank you.